Welcome, ladies and gentlemen. Hello. Let me invite you all to take a seat. Welcome to you all to this session on fostering health system resilience in fragile and conflict-affected countries. My name is Vismita Gupta-Smith. I work for the World Health Organization for the Department of Communications as the head of Communication Strategy, Planning, and Coordination. Thank you very much for being here. We have a very interesting panel. Ladies and gentlemen, let me invite you to please take your seat. Ladies and gentlemen, the UN at this time is dealing with multiple emergencies of different kinds: earthquakes, floods, conflicts. And we know that fragile health systems are also expected to deliver ongoing services when conflict strikes, when disaster strikes. They're also expected to deliver while they're dealing with the impact of climate change, something that we all live with every day. In this panel today, our experts will talk about different aspects of resilient health systems, how to foster them even in fragile settings, in countries that are affected by conflict. We know that even in times of emergencies, babies continue to be born, and people need life-saving medical help. All of that has to be delivered with innovation, with very few resources in countries that have fragile health systems. This session is happening in the shadow of the events that are going on in the Middle East. Our World Health Organization's Director General, Dr. Tedros, yesterday condemned strongly the attack on civilians in Israel, because this is a session about fragile health systems. Let me paint you a picture from Gaza. WHO is pleading for immediate reversal of Gaza evacuation order to protect health and to reduce suffering. As a mass evacuation is underway in Gaza, patients, health workers, and civilians are witnessing disaster. The Palestinian Ministry of Health has informed WHO that it is impossible to evacuate vulnerable hospital patients without endangering their lives. When we talk about vulnerable patients, we are talking about mothers with complicated pregnancies. There are many women in the room. Raise your hand if you had a difficult pregnancy and delivery. My daughter was born a preemie. She was 4 pounds and 4 ounces. She's now 18 years old, going to university, a healthy child. But she was very lucky to be born in one of the best hospitals in the US, where she spent a month in the incubator after her birth. We are now asking 1 million people to move while they're under attack, while the health facilities are under attack, and we are evacuating patients, newborn babies, in incubators. WHO has described the evacuation order as a death sentence for the sick and the injured. So we will, in this context, in this fragile world that we live in, I will invite our panelists to come in, who each of them have immense experience in their countries, in the countries where they serve, to work in very difficult conditions and have valuable lessons in building resilient health systems. So let me get started. Our first panelist is Dr. Jorge Moreira da Silva, UN UN Undersecretary General and UNOPS Executive Director. Previously, Dr. Moreira da Silva served as the Director of the Development Cooperation Directorate at the OECD, and he was also Portugal's Minister of Environment, Territorial Planning and Energy, Secretary of State on Environment, and Secretary of State on Science and Higher Education. Dr. Moreira da Silva. Thank you. George, you've had a career of experience working with fragile health systems. You've worked on solutions for climate change as well on the ground. First, let me start by asking you, how is your UNOPS staff doing in Gaza?
Well, Vismit, as many of us, including my colleague Tedros, we have been following in a permanent basis what is happening with the population in Gaza. And let me also start by condemning in the most emphatic terms the attacks that affected civils in Israel. But let's make no mistake. The civilian population of Palestinians in Gaza cannot pay the price of the brutality of Hamas. So I think it's very important, as the Secretary General has been saying, that first, we need to release the hostages. We have to reverse the order to evacuate the civilians in Gaza, because it's impossible. It's impossible to do the evacuation without dramatically affecting the security, the well-being of the citizens there. It's important that the humanitarian international law is fulfilled in its, all its terms. It's fundamental that the humanitarian corridors are open to make sure that water, all supplies, food, and medicaments can be provided. The Secretary General this morning said, we have all these stocks in the neighborhood, in the border. In a few hours, we can release the food, the medicines, the water that is needed. Let's open the corridors. We need those humanitarian corridors to be open, and this is fundamental. I insist, the civil in both sides cannot be affected. And you asked me about my team. As you imagine, all my thoughts are with the population that are being affected, but also with my colleagues that are there providing all the support that is needed. They are also under huge insecurity. They were also asked to move because they were not safe in the north. They are also being a target because they are in the middle of the bombing. So they went to a safer place with the population, but they are heartbroken because they still want to support the population. So, of course, all the projects have been suspended. I hope that we can restart the soonest, but we can only restart when the security, the safety can be provided. So, as you imagine, this situation is alarming. What will happen in the next hours may affect the next decades. So I still hope that the situation can be reversed and the people, the children, can be protected.
Thank you, George. Let me invite you to take your seat. Let me, as I invite our other next panelist. Our next panelist is Dr. Samuel Roger Kamba. Dr. Kamba is the Minister of Public Health, Hygiene, and Prevention in the Democratic Republic of Congo. He is a pediatrician with over 30 years of experience. He has also served as special advisor in charge of universal health coverage in the DRC and as coordinator of the Presidential Task Force to combat COVID-19. Welcome, Dr. Kamba. Dr. Kamba will speak in French, and we have interpretation here. But my French is not very good. My apologies. So I will ask you in
Neither
English.
my English.
Okay. All right then. Because how many languages do you speak, Dr. Kamba?
Oh, more than 4.
More than 4. And I do too. I come from India originally, so I speak 4 languages, Indian languages and English, but I'm still learning French. So my apologies for that. So Dr. Kamba, your country has faced Ebola and has had a lot of success in containing outbreaks quickly. Talk to us about the resilience that you have built in the health system in your country.
Thank you. The first thing I have to say is facing Ebola for many, many times transform you, because it starts as a illness which is very, we become afraid when we see people with Ebola. But facing the first, the second, the third, until the 13, you become resilient. Et pour cela, il y a beaucoup de choses que nous avons appris. Et aujourd'hui, nous aidons d'autres pays à combattre les épidémies de manière plus efficace.
So we've faced Ebola a number of times, and due to that, we've learned a lot of lessons and shared it with other countries on how to combat Ebola and how to be more resilient in facing this type of adversity.
Et ces expériences nous ont permis de lutter contre Covid-19 et nous ont permis effectivement de connaître les réactions à avoir devant une épidémie.
And this has helped us to combat COVID-19 and given us a lot of tools to face these type of pandemics and outbreaks.
Mais je peux vous assurer que avec COVID-19, avec Ebola, nous comprenons l'importance de la préparation à une prochaine pandémie et nous comprenons l'importance de préparer cela surtout dans les pays fragiles.
So with Ebola and COVID-19, we understand preparedness, how to be prepared in face of these type of outbreaks and pandemics in case there's other or future similar pandemics and outbreaks coming along.
Et je crois que la leçon majeure, c'est qu'une épidémie ne doit pas être considérée seulement localement, parce qu'elle peut devenir une pandémie, et donc n'attendons pas pour nous préparer.
So I believe, the Excellency believes that an outbreak shouldn't be taken into a local perspective alone. It should be an international issue so that it doesn't affect the wider population.
Merci beaucoup.
Thank you.
Thank you very much. Please take a seat. And our next panelist is Dr. Buhaibe. Dr. Qasim Buhaibe, Minister of Public Health and Population in Yemen. Dr. Buhaibe led Yemen during the COVID-19 pandemic. He led the health response in Yemen. He has also been leading a comprehensive reform in the health system in Yemen. Welcome. Dr. Buhaibe, talk to us about your country's experience in delivering oxygen during the pandemic, during the second wave, when you were also dealing with the conflict.
Okay, thank you, first of all, for invitation. And before asking this question, I want also to comment any act against any civilian people, whatever their color or whatever their religious or their race, because as we know, as health care professional, we always look at people as unique and one for all of them, and all of them need to be treated as all, and not look at pain of some people and ignore the pain of the others. I need all people should be treated as equality, and I think without looking for this, we can reach to peace and equality and resolving a repeated cycle of violence as we see in Gaza. Regarding your question, yes, during COVID-19, I remember the story of oxygen demand. You know, there was severe demand on oxygen for patients of COVID-19. And most country, while my country was in violence and in conflict, we have very shortage of oxygen plant. And I remember one story regarding Taiz city. Taiz is a crowded city, about 2 million people, that there is multiple military control of it and around it. And to supply by oxygen, we need to travel to another city to bring for them oxygen. And I remember in second wave, there was like explosion of one oxygen factory or oxygen shortage in Jordan and many accidents. And we are afraid to have the same problem. So for 3 nights, we was in operation in EOC, Emergency Operation Center, to how to supply oxygen to this city. And we deliver oxygen from the east of Yemen, from Marib, by about 1,000 kilometers, and to supply for 3 days. While in normal situation, it can be 10 hours. But because of this multiple military control and of this conflict, we have to run around and we have negotiation with many forces in the ground. So this is an example of how the conflict can affect even essential supply. And from this point, we now implant many oxygen station in every government to avoid this problem that happened in that time. Thank you.
Thank you, Dr. Buhaib. Please have a seat. So we will talk more about how Yemen has scaled up this oxygen supply, also the cold chain, a little later in our session. My next guest is Dr. Petra Khoury, Director, Health and Care from IFRC. Dr. Khoury led the National COVID-19 Response and Vaccination Plan in Lebanon. She's an American and a Lebanese. She served as the public health advisor to the Prime Minister of Lebanon. And prior to her leadership role, Dr. Khoury also served as the executive administrator at the Medical Center on Re-engineering the Delivery of Healthcare at the American University of Beirut Medical Center. Please, Petra. So, Dr. Khoury, talk to us. You have a lot of experience working with the health system in Lebanon, but you were also present during the Beirut blast in 2020. Talk to us about that.
Thank you. Good morning. The reason the Beirut blast is important because this came in the middle of a pandemic. August 4, 2020 was a time where everybody was fighting a global pandemic. Health systems were developing capacity to treat COVID patients. We were in the middle of a wave. Hospitals were facing, emergency departments were queuing patients. And suddenly on August 4th at 6 p.m., in 10 seconds, the largest non-nuclear human-made explosion in the history blasted. And it affected 7,000 casualties, 218 deaths. And the system had to transform and absorb. And in that time, I was leading the COVID-19. I was senior advisor to the Prime Minister, and sitting in my office, and in the middle of doing meetings, this happened. And we had to, in seconds, respond. The mass destruction that the explosion caused, which extended to more than 10 kilometers in depth, a city that caused displacement of 300,000 people, where their houses were completely demolished. And you had to respond. Ambulances had to reach. But the key point here is that 3 major largest hospitals of the country were in that zone, and they got demolished. So not only we had to treat people in their houses and on the streets, we had to evacuate hospitals and transport patients to outside the city. And evacuating hospitals, by itself, we were just talking about how we're asking people to evacuate. Evacuating hospital, when the hospital is demolished, is a challenge by itself. Healthcare workers had to provide essential health services on the streets, in hallways, in corridors, on the stairs, everywhere, with debris all over, glasses shattered. This was possible because the system over years in Lebanon, and because of fragile and conflict setting, has developed resistance and resilience to be able to absorb shocks and transform within seconds. And finally, I started the day as a healthcare provider, as a senior advisor of the Prime Minister. I ended the day as a patient because I was also injured. I had a brain injury. And I was in the middle of this, and I saw with my colleagues, and I saw in the citizens, the fight of a health system that was trying to provide services to save people. I might not have been here had the system was not being resilient and prepared to transform within seconds. Thank you.
Thank you, Petra. We're really glad you're here. Our next panelist is Dr. Jarno Habicht, WHO's representative to Ukraine. Dr. Habicht is a young, old WHO timer. He's a young man who's worked for WHO for almost 20 years. And during this time, he also led the WHO missions in the Republic of Kyrgyzstan, Republic of Moldova. And in the past 5 years, in Ukraine, he's been leading the WHO team to facilitate supporting health sector reforms. Ukraine had undertaken reforms just before the pandemic, address disease outbreaks, respond to the pandemic, and respond to the humanitarian situation due to the ongoing war. Dr. Habicht? So Jarno, when you joined WHO in Ukraine, you were going to witness, you were joining a country which was going to undertake the fastest and largest health system reform in Europe. And I just described everything that the country has gone through. Ukraine's health system is not a fragile health system. It's actually would you describe it as a strong health system before the pandemic and the war?
Thank you. And probably I'm not so young anymore. I'm coming from northern part of Europe. It's so cold all the time, so it feels like you grow up in the fridge. But but when we come back to Ukraine, I think what Ukraine tried to do in 2016-17, moving forward with the reforms, establishing the ways of health financing which are new, moving to the digital, having the data available, ensuring that the primary care is in the center, but not forgetting also what we talk probably today about the procurement, ensuring that there is no corruption, to establishing also new institutions. I think that has been extremely important when we look now back to the disease outbreaks, be it the measles or polio outbreak that was closed just months ago, or response to the COVID, as well now since Russian Federation invasion 19 months ago to the war. So this is where. But when I was traveling here, I was thinking what the resilience would mean. And colleagues shared many of the stories. And let me just reflect also one. When I was in the summer this year back in Kharkiv and traveling with the colleagues other side of the minefields, looking how the primary care doctors work. You go on more than 20 minefields. We are supporting also those nurses and doctors to be there. They have put up the temporary facility, and you see actually the grandparents coming there to receive their medicines, ensuring that their chronic diseases are under control because they don't want to leave the homes. You see the children cycling around that center, ensuring that their grandparents are getting the care and so on. That gives you a bit of the hope. And then we were traveling further to one of the modular primary care clinics we had installed because the previous primary care clinic was just destroyed, getting the direct shelling. and we have seen more than 1,200 attacks on health as a WHO and monitored and documented them, then you see actually the nurses and doctors, when they enter to this new facility, you see tears in their eyes because they can again provide the services. You see again the people coming around. And this is something that we also saw in the early days since February 2022, when Irpin, Pucha, Makari were liberated. Then actually what people want to have to go back home, they want to have health care available, they want to have food available, they need to have a drinking water, and that gives them the hope to go back. But when we discussed yesterday what the resilience means, very often we talk about many aspects of health system. We talk about universal health coverage, we talk about how well we are prepared, we talk about many of the things. But one thing I have learned and appreciate a lot in Ukraine over the past years is actually the resilience which comes actually from the healthcare workers that we very often forget when we are reforming the systems moving towards universal health coverage. It's actually the nurses, the doctors, but also all the technicians who are there in the facilities who give that resilience to the health system. So I think that's something that at least stays with me, is really those who are waking up, going to the field, ensuring that the services are available in the same way like the colleagues
serve, right? So while we build resilient healthcare systems, taking care, and while healthcare centers and health workers come under attack, especially in conflict-affected countries, how do we ensure that we continue to provide, that these systems are able to provide much-needed care in those settings? So, colleagues, let me invite you next to watch a video about the rehabilitation of health facilities in Yemen. This project was funded by the German Federal Ministry of Economic Cooperation and Development, and it was implemented by UNOPS. Video, please.
كان مستشفى السبعين للأسف رغم أهميته ورغم أنه يقدم خدمات لعدد شريحة كبيرة جدا من الناس يعجز عن تقديم هذه الخدمة بفعالية وبجودة عالية بسبب التهالك الذي موجود في مستشفى السبعين. كان المستشفى في حالة متهاوية بشكل كبير. عملية الترميم لم تكن فقط عملية ترميم شكلية، ولكنها مست البنية التحتية داخل المستشفى. حدثت توسعة كبيرة في أقسام المستشفى.
بعد التحديثات اللي حصلت تحسن الوضع بفارق يعني كبير. ارتحنا في العمل، قدرنا نرتب وننسق، اختلف الوضع تماما.
Thank you. So let me start this part of our session with you, George. Health makes up over a third of UNOPS project portfolio. Talk to us about the type of support that is needed to strengthen health systems in fragile settings.
Thank you, Vismita. And the topic of today's session is about system resilience on health in fragile and conflict-affected countries. We all know that fragility is multidimensional, involving social, environmental, economic, political, and security dimensions. But we see two drivers that are exacerbating the existing fragility context. It's conflict and climate. And the numbers are quite eloquent. 80% of the poorest will live in fragile context by 2030. And now 25% of the population in the world live under conflict. And we also see that there is a correlation between climate and its impact on health. The numbers are known, $2.4 billion per year by 2030 will be the minimum impact of climate on health systems. So in this context, what are we doing, UNOPS, and why are we playing this role? I think that in addressing the fragility dimension, in rescuing the SDGs and the Paris Agreement and the financing for sustainable development agenda, there are three key dimensions. One is finance. We don't work on that, so we don't provide finance. The other is policy, creating the enabling context, policy reforms, dealing with the global architecture, but also with the national context. That's not a role for UNOPS because we are a non-programmatic agency. But there is a third element, a third gap that is fundamental to address. Because sometimes you may have the money, you may have the policy, but you still cannot deliver. Why? Because you are missing capacity for implementation. So it's very important, this operational dimension, get things done, and it's the role that we are playing. And on health, it's very important to play it in a coordinated manner with the other agencies and in partnership with the government. So it's not possible to address health resilience without the governments being with the civil society, with academia, with the private sector, very much engaged. So the role of UNOPS is partnering to expand our partners' capacity for implementation. Just 2 or 3 examples, not to go into much detail. One was Yemen. So what we saw in the video is showing our role in rehabilitating 7 hospitals. Another example is Gaza. The solarization. One of the 3rd largest hospitals in Gaza, that is the main hospital, was the main hospital for the COVID treatment, was facing, as many hospitals in Gaza, issues regarding energy supply, instability on the electricity system. So we implemented a massive solarization effort in that hospital, so it's the European Gaza hospital, with solar energy that now has a clear advantage. The bill, the bill that is paid by the hospital was dramatically decreased in terms of cost. There is no instability on the operation because energy is there, and we also make it more sustainable. It's another example. The same, I would say, in IT. We know the impact in IT from hurricanes and earthquakes. So we have been working in construction and rehabilitation of hospitals, making sure that the infrastructure is resilient both to climate events but also to earthquakes. And finally, in Ethiopia, we have worked supporting the government in the south, again on the rehabilitation of centers, health centers. So you can see some concrete examples of why UNOPS, partnering with other agencies and with the governments, can support this operational dimension, so the capacity for implementation.
Thank you, George. So let me invite you, Minister Buhayev, if you could build on what George has said and talk to us about how in Yemen you have built resilience in the health system.
Yes, of course. The situation in Yemen, really after 9 years of conflict, it was challenging how to make priority also in the health system and also how we are making resilience of the health system. So we are first make our priority that can be divided. First of all, primary health care services should be applied for all the country. And we focus many of our resources, even our partners, how to supply the primary health care service around the country, because as mentioned in the video, only 50% of the health facility is working in Yemen. The other 50% not working, either to do direct damage to the war or operational cost insufficient or health care insufficient. So we make focus on primary health care service. As mentioned, our colleague, also we have great challenges in electricity. So we are focused how to increase the solar energy. So almost 50% of the health facility, especially in the primary health care, are supplied by UNOPS. And in this regard, we thank our partner UNOPS for great support with other partners, either from German Development, KfW, or World Bank, that almost solarization of the health care, especially in the primary health care. And also we are regarding the secondary health care, as you saw in video, this like this hospital, Sab'in Hospital, is the main hospital for women and children in the Sana'a city. So we focus most of the intervention to be directed to the main hospital in the great city. So because of the limited resources, we cannot operate all centers, so we make sure the primary health care is sufficient. So we are vaccination available, nutrition, maternal and health care sufficient, and also nutrition to be avoid malnutrition and the problem of that. And then look to the secondary health care, how to make priority, how to be maintain dialysis center, maintain cancer center, maintain cardiac center, and the main hospital. So by this, in every city, at least there is one large hospital that can be dealing with the secondary care. And in this regard, we focus on how to sufficient energy, support sufficient health care, because in every conflict and in every instance, we are facing of migration of the shortage of the health staff and migration of the health staff, because of the many of the healthcare professional migrated even to outside the country or even inside the country to private section, because there is more money than the public facilities. So how to replace this shortage of the healthcare? We more focus on how to make diploma or short courses, how to rehabilitate many healthcare to replace this shortage. And so we focus how to, in this main hospital in every government, there's full energy, full healthcare and operation cost, because this is one of the great challenges in every fragile or countries, that the Ministry of Health, they are limited budget for it. The main budget go to military or go to security forces, but to Ministry of Health, they give 5 or 2 or 3% of the budget. So we cannot submit. So for this, the operation cost is challenging. So we have to focus in this main center, so we can know that every patient in every city there is at least primary health care is maintained, and also the main hospital in every city is operated good. And as you say, it was one of the priority for us to invest more in infrastructure, because during the war there is no maintenance. As you saw in the video of a Sab'in hospital, there is a lot of need for rehabilitation. So we thank for this great project that's supported by Chairman Development. About more than 25 health facility was rehabilitated, the main health center, and they built also during COVID many isolation center. That was a great support for us. So by focus on the infrastructure and focus on the clean energy, that is by solarization more of the health system, and by more investment in the healthcare new to replace the shortage of the health, and by fighting Minister of Finance for the budget. So by this I think we try to maintain the resilience of the health system in my country. Thank you.
Thank you, Minister Buhaib. I will come to our other panelists, but in the next part of this session, I hope when we have a discussion, you can all talk to us about techniques and strategies to fight the Minister of Finance for funding. I think that should be part of building lessons learned to build resilient health systems. So, colleagues, we now have a short video about a program funded by EU in East Africa to tackle the health and social economic impact of COVID-19 pandemic. Video, please.
قلنا هني تعبس عسولي سكولو مكينة سنة اللي تفرق سكولي ليه قد بابي اللي نكادنا نقولي أو ليه كده وعدي أصلا ممكن نحبط هنا نحن التا وفورا سنة نكاه بنبط هنا نحن أما قال في التوات ساقو وهو يمكن نحتاج وقت نحن.
Thank you. So let me come to you now, Minister Dr. Kamba. You described how in your country, after 13 Ebola outbreaks, you have developed resilience. But actually, even while you're dealing with these outbreaks, your country has made significant improvements in immunization, in oxygen and cold chain supply. Speak to us about that and lessons that can be applied in other fragile and conflict-affected countries.
Thank you very much. When we come to power, we had 32 children who had been full vaccinated. It was very, very low, and many of them were facing many illnesses. But what the president did, he called everybody. He called the governors. He called all the stakeholders together. And we made a very, very big engagement, a commitment. We called the Minister of Finance. Everybody was in the room. So we told them, okay, we are facing a very big problem. We have 32 children who are full vaccinated. And we cannot stay just like that and go forward. So everyone have been committed, engaged. And then we made a kind of summit, and from there we have a declaration of Kinshasa, where everyone was engaged. And we put money. It was a very, very big priority. Et à partir de là, nous avons distribué correctement les vaccins qu'on avait déjà reçus, mais surtout, on a payé tous les vaccins de routine, en plus de ce que Gavi devait amener.
So once the commitment was established, we purchased and distributed the vaccines appropriately and paid all the costs incurred with respect to those vaccines.
La première leçon, donc, c'est vraiment un engagement politique très fort au niveau des chefs d'État qui doit permettre, en fait, de mettre de bonnes priorités.
So the first lesson here is the political commitment, especially from the head of state, that puts the policies together.
Et puis ensuite, faire des bonnes priorités, parce que même dans les pays fragiles, on a quand même des moyens que l'on peut orienter, mais il faut les orienter correctement.
So the second lesson is to determine and establish appropriate priorities, because once you have your priorities set, then you can move forward.
Et comme nous avons défini la santé comme la priorité numéro 1 après la sécurité, parce que nous avons aussi des problèmes d'insécurité à l'est du pays, comme vous le savez, quand vous avez déterminé donc la santé comme priorité numéro 1, maintenant vous pouvez déployer cette stratégie avec surtout les travailleurs communautaires.
So once you've established health as a number 1 priority, after security obviously, then you can deploy the strategy starting with community health workers.
Mais en plus, il faut ramener les donateurs dans un système intégré, parce qu'on a vu que le système qui est très désintégré, où les choses se font en silo, malheureusement, on n'est pas très efficace.
But you have to bring all the partners into an integrated system, because history has shown, and we've seen, that working in silos doesn't really provide optimal effect.
Juste pour vous donner un exemple, quand on a été dans la lutte contre Ebola numéro 10 de 2018, nous avons dépensé 1,2 milliard de dollars pour soigner plus de 3000 malades et sauver seulement 1000.
So, just to give you an example, when we fought the Ebola outbreak in 2018, we spent $1.2 billion were spent to treat only 3,000 people and save 1,000 lives.
Et quand vous regardez derrière, après cette dépense très importante, il ne reste aucun signe sur terrain, ce qui montre que le travail désintégré ne permet pas la résilience.
So once the fight against Ebola was completed, what you can see on the ground is there's no lasting effect on the ground, no signs of an outbreak coming, and no infrastructures left. So you can definitely see that a disintegrated system of work is not optimal.
Et puis donc, il faut adapter les solutions localement. Par exemple, pour la chaîne de froid, le vrai problème, c'est l'énergie. Et donc, l'énergie solaire nous a beaucoup aidé à maintenir le déploiement de la chaîne de froid.
So you have to put in place adaptive financing solutions. For example, for the cold chain issue, what we did was we went with the solar energy.
Et nous avons vu aussi l'importance de la production locale et de maintenir cette production, notamment de l'oxygène, quand on luttait contre Covid. La première difficulté que nous avons vue, c'est que notre système était très très pauvre en oxygène, et c'était devenu une grosse priorité.
And we can also see that, for example, with respect to oxygen production, it's important to develop local production. We've seen that in our country, access to oxygen or production of oxygen was not where it was supposed to be. So it was one of the things that we worked on.
Et quand on a utilisé des solutions locales, il faut maintenant faire un très bon suivi, un très bon monitoring, parce que souvent, ce qu'on a vu, c'est qu'on déployait des solutions, et on pensait qu'elles allaient tourner d'elles-mêmes, mais les solutions ne tournent pas d'elles-mêmes. Il faut le suivi et vraiment un bon monitoring pour nous rendre compte si ce que nous faisons est efficace et être flexible dans la réadaptation.
So once you deploy the strategy and determine the type of investments to make, you also need an adequate monitoring system as a follow-up strategy, because systems don't work alone. You definitely need monitoring to make sure that the objectives are met.
Moi, je pense sincèrement que la plus grande leçon que nous avons apprise avec ces différentes épidémies, c'est que même dans les pays fragiles, surtout dans les pays fragiles d'ailleurs, nous avons besoin d'un système capable d'être adapté localement et capable d'être bien surveillé pour qu'il n'entraîne pas tout le reste du système dans l'échec.
So what we've seen in fragile countries is the system needs to be monitored and followed upon, because that's the only way to achieve the optimal objectives.
Actuellement, nous avons encore beaucoup d'épidémies comme monkeypox, comme polio, comme measles. On a encore toutes ces épidémies qui sont en cours, et je peux vous assurer que les choix qu'on fait, ce sont des choix qui nous permettent de réagir très rapidement. Et aujourd'hui, quand nous avons une fièvre hémorragique, par exemple, suspicion de fièvre hémorragique, eh bien, en quelques jours, nous pouvons contenir cette fièvre hémorragique.
So we currently have a number of different outbreaks in our country, but we have established a strategy to tackle these as quickly as possible.
Voilà à peu près les grandes leçons que nous avons apprises de toutes nos épidémies, et notamment la résilience avec le système de froid et la vaccination.
So those are the lessons that we've learned with the different outbreaks, notably with respect to the cold chain and immunization.
Thank you, Dr. Kamba. So in this conversation later, let's come back to the role of building resilient communities too, which will, who will need to, in the case of a conflict or a crisis, need to be equipped well, right? So we'll come to that in a minute, but let me come to you, Petra, Dr. Petra Corey. Talk to us about building resilience in a health system, especially from the perspective of the impact of climate change. And also talk to us about universal health coverage. How is that delivered in health systems that are fragile and also affected by conflict?
I'm going to talk now not just as a director of health at the Federation, but also as representing the Red Cross, Red Crescent movement, specifically during these times, because I want to take us back a little bit in time. 162 years ago, the Red Cross was founded because 30,000 people in conflict did not receive any medical care and medical assistance. And that's how the Red Cross mission was founded in Geneva by the Geneva Convention, to say that anyone, everywhere, in the middle of a conflict or not, needs to have medical assistance, impartial, neutral, to service them. And there we are today, 162 years later. We are still talking about situations where people are not able to receive what they need in terms of medical care and the challenges. The latest developments that we've seen, whether it's in Israel, Palestine, Sudan, Ukraine, Yemen, DRC, and many Syria, and many, many other places, we came to realize that if we don't build resilient and protected systems, and I want to emphasize on the protected systems, and I'll come to it, we're not going to be able to face and deliver care to the people in need. Whether it is war, climate change, these are all reasons that forces us to build resilient systems. What do we need to have a resilient systems? Esteemed speakers before mentioned building local capacity. That's exactly what is needed. We need to build a local capacity, and local capacity is about building local health workforce, training local health workforce. It's about ensuring that the countries in fragile and conflict settings have essential medicines, essential equipments, stock on hand enough for them to survive shocks. It's important that we are there before the outburst of the crisis so that we are able to respond during and survive after. The minister mentioned that after the crisis, the system was dismantled and there was nothing, because we need to build before so we survive during and after. The third one is about facilities. The facilities have to be ready to be able to survive the shocks, and they need contingency planning. So that's on the resilient part. I want to get to the protection part. And the reason I want to talk about the protection part is because of what we've been hearing. In the last year, 700 attacks have happened on health facilities and healthcare workers in 2022. People go in conflict and fragile settings to health facilities as a sanctuary of healing and hope. It cannot become a battleground. When we target health facilities and healthcare workers, we're depriving the people of need to get the services that are highly needed. That's why my plea is for all of us to unite and advocate that unequivocally we need to stand by the fact that healthcare facilities and healthcare workers should not be targeted. International humanitarian law must be upheld. We need all parties in a conflict. They must respect their obligations to the international humanitarian law. This is non-negotiable for all of us here, and for us as a Red Cross, Red Crescent movement. This is at the core of why we exist and how we deliver care in 191 countries where we are present. The third one is about coordination. All of us here. We need to coordinate as partners delivering care in these settings so that we ensure that there's a comprehensive plan when we're facing any adversity, any challenge, we are complementing, and there's a comprehensive plan for better health outcomes. And the last point is about advocacy, and this is what we're all doing here. We're advocating for the need for the global community not to forget fragile and conflict setting, to invest in these situations in these countries. Miseries have no borders. They're gonna cross. We saw it in COVID, and we're seeing it everywhere now with the migration, with the flow and movement of people. There's no more borders in this world. We need all of us to work together in different settings to build systems that are resilient and protected. Thank you.
Thank you, Dr. Corey. Dr. Havik, Jarno. So 1,200 verified attacks on healthcare centers, right, in Ukraine. What are the lessons we have learned? Because this was not a fragile health system, but it has had to suffer the shock of, well, the pandemic, and also you're now in the 18th month of an ongoing war. Talk to us about the lessons learned.
Thank you. And there are many lessons, but we have lunch break as well. So let me bring few, because I think as any war, conflict, it evolves and we constantly learn. And I think this panel has been also very useful, that we learn from different countries and share the experience. And I think many of the health systems are going through huge stress tests. And the key question is how we can learn from each other, and how we can ensure also, as we are progressing towards the universal health coverage, how we make our health systems more resilient and prepared and so on. So a few things from Ukraine and thinking back the last 2 years. First is really that we simultaneously need to work while responding to the war and crisis and saving lives, actually to the recovery and moving forward with the reforms. And this is something we have been discussing with the Minister of Health in Ukraine, with many of the stakeholders, with the communities, that recovery starts right now. It started in the first days of the war. And let's think back when people get a shell in their house, they get the roof of the house which is damaged. What people do, they fix the roof, they do the gardening. When we were back in the spring in Irpin and Pucha, everybody was planting potatoes because they said there is a next year. And we were asking, but war is going on. And they said, yes, but in autumn we need food as well. So from the community point of view, the recovery starts right away. And I think that same we need to do in health. We have seen that in Ukraine recovery and reform conferences in Lugano, in London, a lot of discussion, should we start recovery right now? But actually it should start. And what I have seen, that half of the healthcare facilities which have been damaged have been restored. One of them we were visiting with Tedros and Mike back in May in 2022, a center where the COVID vaccination was done. Got the direct hit, there was nothing left. Now it is fully restored with actually community funding, with private sector funding, and it starts. So that's another aspect. Recovery is not only about the donors and partners, it's also how actually the community comes together, the local partners to come together, and it starts right now. So one lesson learned, everything needs to happen simultaneously, and sometimes we are not ready mentally to actually support that. And what we have seen in Ukraine also is that actually transforming the health system towards UHC, doing the reforms on health financing and others, that has helped also to start recovery faster. So doing proper healthcare reforms actually helps you to be better after. But also we can learn from COVID responses, many other outbreak responses, as the ministers have shared here as well. The second lesson really is that the recovery needs to be smart. We should not build everything back that was there before. We need to think about the climate change. We need to think about the future. So we need to build back smarter. But I like what also Petro was saying about the coordination. That's an important one, because we need to do that in the coordinated way as well. To do the smarter, build back greener, but look also where the population is. because also what we have seen in Ukraine, we have more than 7 million people who have left the country. We have another 6 million who are in different places. So we need to adapt to the future. We need to adapt to changing needs, and we need to be extremely agile. The third lesson, what we have seen really is that recovering health system quickly builds a lot of trust among the community, because that's what people want to have. They want to see that actually they can see their doctor, they can have medicines. In the early days of war, what happened in Ukraine, that 65% of pharmacies were closed. Still, many are not open. Many will never be opened because of the changing economics, the logistics, and operations. But then the key question is how we can ensure that the doctors can hand over the medicines, because that allows people to go back and continue to their lives. So we need to do multiple actions at the same time. We need to ensure that the recovery is smart, and then we need to realize that early recovery and starting right away builds a lot of trust in the community. And final point, I think what I have seen now at the time of COVID and at the time of war, we need to realize that the health needs are actually increasing. And that's something that is probably a very difficult discussion with other sectors, with the ministers of finance, how to ensure that the funding is there. Because in Ukraine, what we see, there are increased needs for rehabilitation, huge needs for mental health, but then also we should not forget the delayed care and the care what is needed for chronic diseases, non-communicable diseases, etc. So at the time of conflict and war, the health needs are large, but we should realize that even after, the needs are even bigger. So this is a challenge ahead of us, how to manage that one in the coming years to come. Thank you.
Thank you, Jarno. I like that image of Ukrainians planting potatoes as their houses are being bombed, because there will be a next year, and we have to plan for food next year. And we can't wait for the conflict to be over to start building. When you're building, build back better, smarter, and build and work to build trust in the communities. Thank you for that. We will come back and talk about communities later, but now another short video, this time from Ukraine, showing the importance of reliable energy supply for providing critical and life-saving healthcare even during conflict and a volatile situation. Video, please.
Дизель-генератор нам допомагає як і в повсякденній роботі, тому що мережі, на жаль, в воєнний стан можуть бути пошкоджені, тобто він буде допомагати врятувати багато життів при виконанні складних операцій.
Thank you. So before we open the floor for questions from all of you, we have another speaker, Marlies Seeberger, from the German Development Bank, Head of Division for Health, Education and Social Protection in Sub-Saharan Africa. Welcome, Marlies. So talk to us from the perspective of partnerships and the role that they play in building resilience in health systems.
Yes, thank you very much for having me here. I'm, as mentioned, responsible for health, education and social protection in Southern African countries. I have recently been to Mozambique, and that also kind of brings me to my intervention. Please bear with me, I have a doctor title, but for public finance. So I will bring vocabulary like division of labor and comparative advantages and efficiency of spending public funds. Because we learned from the example from Yemen that we as German Development Bank cooperate with UNOPS in such a fragile and conflict-prone area because we really have to look how to be most efficient in a setting where it's difficult to just rely on the standard approach that we in German development cooperation, in my field, financial cooperation, are usually applying. So usually we work directly with the Minister of Health, assisting with some consultancy, and then implementing the investment program of our partner countries. So in conflict and fragile areas, that's no longer possible the way we do it normally. And so we are very happy to rely on partners like UNOPS that then actually are in a position to deliver the same kind of program we wanted to assist our partner country with the funds from our Ministry of Economic Cooperation and Development. So from the German policy decision to help a certain country in the area of health, and then how to bring actually this to the people. And another aspect is transitional aid. This is also from special funds, which have in mind what also the colleague from WHO for the Ukraine was stating, having in mind that it's not just a humanitarian response at the sudden, but also to think about the resilient system that needs to be built, so to bring also infrastructure and equipment. And what I learned also from this session here is how much motivating this is for the health workers. Because when they really feel that they can do their work properly and help people, because they are also well equipped for this, that also motivates them even stronger. And that's what really makes the system resilient. So these come together. But my intervention here is also to flavor the discussion a bit. Please allow me to bring in other UNs as well, as I had seen in Cabo Delgado in the north of Mozambique. There we rely on UNICEF, and so my intervention is really to the ministries of health, but also to WHO, to move forward the coordination, because coming back to my first statement, comparative advantages, look where we can most efficiently apply what services on the ground. And I learned from that experience that UNOPS is working with UNICEF in WASH interventions together. So what I would also like to hear a bit about is how actually to bring the coordination into being, to make the most efficient use of this scarce public funding we have. We learned also the Ministry of Health faces this problem of scarce financing. So we need really to be the most efficient one in that field. And so I would be happy to learn a bit more about this. Thank you.
Thank you very much, Marlies. So, let me come to you, Jarno, with Marlies's question. It's the coordination that is the big job in any situation, especially during conflict, to identify priorities, to make sure we make the most efficient use of very scarce resources. Could you speak to us about that?
Thank you. And I think there are a few aspects and very important ones. I think one, what we have learned during the COVID and having the COVAX facility and having very close cooperation exactly between the WHO and UNICEF, but also with many other partners, I think that is important. And exactly, there are partners who are doing much better, investments to the cold chain when we think about the vaccines, where from WHO side, we are coming with the policies, we share what needs to be done. So I think in the field, I have seen a lot of similar cooperation, but that needs a lot of goodwill, certain principles, and that we adhere to those principles as well. So that is something that I think we agreed somewhere in 1980s, where the IHP Plus principles, and so I'm not so young anymore. We should go back to those and think how we actually adhere to those principles of good practices, that we have platforms available, we have national plans available, we keep ourselves accountable for that, and that's what actually the UHC 2030 platform is also there, hosted by WHO and the World Bank. So that is something that we have many good examples, but we need to do more of this in the field. The other lesson that I look particularly in Ukraine is that how we coordinate between the humanitarian and development partners. Because as a WHO, our task is to coordinate the humanitarian partners through the health cluster. In Ukraine currently, we have more than 100 partners actively responding to the humanitarian crisis. And then, of course, we have all the other sectors as well, from WASH to education, etc., etc. But 100 is only in health. But in addition, we have development partners who are investing, looking where to put the budget support, how to ensure that the reforms can continue. And these two groups are very different. And it has been extremely rewarding experience, because at the end of the day, my office needs to coordinate both of them and how to bring them together. Because also very often they have different mindsets, because humanitarian funding is usually for 6 months, 12 months. In the development side, we are thinking about 5 years, 10 years. So I think that is something that we have learned in Ukraine, that we need to learn how to bring these groups together. We need to learn how to bring those principles together. But I think we need to start to look globally, and some of the member states like Norway and few others are taking already very strong steps, how we finance both the humanitarian and the development aid. So sometimes, let's say, challenges in coordination fragmentation is how actually the global health has been designed. So sometimes we need to go back to that one and challenge it, because it's not about people not coordinating. Sometimes the systems are putting the strings there why we don't coordinate ideally. But sure, I like coordination. That's, I think, how I wake up and how I go to sleep, to think about all the partners who are doing a great job, actually.
Okay, now we're talking, challenging the way we do the work to make sure that we're more efficient. George, can I invite you to talk about coordination?
I'm very happy to provide, as Jarno, my contribution to this topic. I think that first of all, it's important to make sure that this is driven by developing countries' own aspirations. So it's not what WHO or UNOPS or UNDP or UNICEF, what we have in our shop to deliver, and then we ask, how can we deliver? It's by contrary. We have to ask what the countries that we are serving need. So I would say that the coordination is fine, is element, but it's important that it's rooted in developing countries' own aspirations, first of all. Second, I think that it's important to go beyond the nice talk about the nexus and really getting it done. Humanitarian development peace nexus, we really need to address it. We are still seeing too much fragmentation between humanitarian development and peace. Mm-hmm. We have to work together in ensuring, when planning, when programming, when financing, that we address the nexus in a compelling manner. Mm-hmm. Prevention always, development wherever possible, and humanitarian as needed. So I think that this coordination is important to be framed by the humanitarian development peace nexus that is, available to all of us. Finally, let's make the best use of the resident coordinator system. We have a UN reform that has put the coordination in the field, so not the coordination in New York, ensuring that all agencies that are there with the donors and with developing countries, that we work together through the UN resident coordinator system. So I think that there are very practical elements, and we are very happy in partnering. It's maybe for UNOPS it's pretty easy, because we are non-programmatic, we are demand-driven, we are SDG-centric, and we are partner-oriented. So we can only survive if we partner with someone, with WHO, with the government, with those that are having the political mandate that we don't have.
Thank you, George. Let me come to you, Petra. Dr. Corey, talk to us about, because you've also seen this from the country perspective. How would you challenge the global architecture so we deliver better and we deliver more efficiently? What would be your suggestion?
I'll bring two perspectives, one at the country level, but also at the global level. I'll start with the global level. The Federation is also a member organization, so we have 191 members, similar to WHO, and in every crisis and outbreak, our members want to support the local community, and we play the role of coordinating among members to deliver care and to deliver services on the ground. It's actually one of our core mandates. And the challenge with this is that there's the internal coordination among the members, but there's the external coordination with the UN system, with governments that we have to play and leverage upon. If one of those is weak, the coordination doesn't serve what it needs to serve. And I think there's more to be done between us and the UN system and governments on the coordination on the ground, because that's bring us back to the community. What the community wants, the heart of the community. I'll speak from the perspective of the Red Cross, Red Crescent. Community actors, and we've seen it in COVID, they have the trust of the people. They're there. They are the brother, the sister, the volunteers that come from communities. And many governments and health authorities and other authorities do not have the trust at different settings. We saw it in the vaccination, where bringing demand to vaccination required mobilizing the whole of a society response. This is what we say, whole of a community response to face pandemics. And that's why bringing this community aspect to the table is key in the response. The first responders in every disaster are the community actors. They are the first ones to get, whether it's an earthquake, whether it's a flooding, the first ones on the scene are usually the community actors, the community health workers, the people that are living in between in these societies and communities. So coordination is good at the global level, but it's key at the country level, under the authorities, with the community playing part of it, to leverage the trust that it has on the community, the reach it has, the surveillance it has, the information it has from the ground.
Thank you, Petra. So colleagues, we have 15 minutes left, 10 minutes left, 10 minutes left, I'm being told, and there is another session after this, and I got lost in our wonderful panel, but your questions are really important. So here's your challenge. Make it a rapid fire. Ask a quick question, no statements. Tell us who you are, who you're representing, who your question to, and the challenge for the panel. Answer these questions in under 1 minute. Okay? Because we want to accommodate as many questions as we can. There are mics in the room. I'm going to start at the back. Lady over there. There you go. We go there first.
Hi, I'm Najeen Mustafa, and I'm representing the disability team here, and we have a session tomorrow, so please, you're welcome to come. I have one question. We have talked about, I've heard you talk about building resilient health symptoms in regions of conflict. Have you considered the inclusion and the protection of people with disabilities in this context? And if there is a mechanism in place for that, and if not, why is that?
Who wants to take that question? Who's your question to?
All panelists.
All panelists.
we
Very
voted
important
for
question. George.
Just in 13 seconds, because what you don't measure, you don't manage. And now there is no excuse. Because ODA, Official Development Assistance, and I know what I'm speaking about because as director of the OECD DAC, I was overseeing the statistics and the rules on development cooperation. For many years, the support to people with disability was overlooked. There was no specific reference code in ODA statistics on that. So it was aggregated on health. Now we have it. So now we know how to get all members, all participants, all partners accountable in that support. So I think that that's much easier now, so there is no excuse.
There is no excuse. Jarno?
Maybe two things. I think we need to do that in the conflict settings, but we need to do it as a part of the overall reforms towards the UHC as well. And this is something we have seen slightly in Ukraine already before COVID, to ensure that access to the facilities is improved. And this is part of the health financing. It is a condition to have those things. So the national systems need to include that. And now we talk a lot about the inclusion also related to the mental health needs and the ongoing needs related to the rehabilitation. So I think it is something that we need to do, and we need to be better in that.
Thank you. Let me see hands again, please. One from the back, one from the front. Okay, sir.
Thank you so much. I'm Dr. Naqibullah Hamdard, right now working as consultant, technical assistant consultant on UNOPS TB project on different countries, and the ex-HIV and hepatitis director from Afghanistan, Ministry of Health. My first request, please don't forget Afghanistan. It's been a big humanitarian tragedy that we have, and the collapse of health system that we have witnessed. It's very good to talk about other countries, the equality is there, so we want our people also be on the stage. Now to my question, that everybody agrees. The cornerstone of resilient health systems should be communities, but how we think? Traditionally, we think we bring our design and we involve communities to train them on our design, involve them in monitoring it. The community empowerment should start from co-creation, where the communities are part of design of the project. I haven't witnessed it in last 2 decades in my countries, being the center stage for development cooperation, and because of the military presence we had there.
And your question is?
The question is how we change this.
Okay, good question. This is a very important question. We wanted to talk about community resilience. Who's your question to, sir? Choose anyone.
Of course. Dr. Khoury, because the work at the ground level can be also your, because they implement projects on such level. I had another one as well, a small one.
There are a lot of people, so hold. Please let me come to Dr. Khoury. Let her answer your question. Let me go to other people.
Okay, no
Thank you very much for a very important point, Dr. Khoury.
Sure, I'll be very fast. Our number one guiding principle is localization as a Red Cross Red Crescent. We're local actors. We support our local Red Cross Red Crescent. As a federation, we do not work on the ground. We come in to support, strengthen, and build capacity of our local members. So what you're saying is absolutely right. We see it in discussion with governments, with donors, how we bring in the local voice to the table to co-create, co-design all the solutions that needs to be implemented at community, leveraging on the trust that we have with the community and the engagement.
The University of Erfurt. My question is around the role of research in all of this. We have been talking about intervention and building systems and building the macro level things. What about research? Because the experience of the population in these conflict settings have not been factored a lot in designing intervention. And that's why sometimes some of these interventions have failed to yield the kind of result that we'll anticipate. The next conflict is going to happen somewhere we don't know. We don't know Gaza and Israel is going to happen 2 weeks ago. So the next one might be around the corner. So what is the role of research in factoring the experience of conflicts within the population in shaping and designing intervention that is to, and the systems that is to build around resilient, around health system in these conflict-affected settings? Investment in research of violent conflict experience is really, really key to building effective intervention.
Thank you. Who is your question to?
Dr. Petra, or probably that is more or less.
There you go. Role of research.
Female, she takes the chance.
Yes.
We want gender balance.
Yes, indeed. Petra, after you, anyone else from the panel who would also like to come? Please, first you.
I agree with everything you said, because we are not so good at doing research specifically at the Red Crescent. We were talking about recently. There's a lot of data, as you can imagine, 162 years of working on the ground. There's vast experiences, lots of things that is happening. The modalities of how we work is the whole time we're running to provide services. There's not a single time we pause and think. There are a few initiatives that we're building to strengthen that pillar of research, but it is not standalone by itself. I'm sure ministries would.
Okay, let me come to you, Jarno.
Similarly, like Petra, I think that's a very important area to invest. I think it might be even more difficult to explain that to the Minister of Finance, but let's see. But what is our role as a community is document, to do the applied research, and this is something I have seen also in Ukraine. We just published a paper just how primary care has been resilient in the first year of full invasion, and that is actually allowing us to learn. So I think it is our job to do that and to explore, document, and do the research around that as soon as possible.
Okay, we have questions, we had videos, we had all kinds of things planned, but we're running out of time, so we're going to take one more question, and then we'll wrap up. So let me come to you, ma'am, right here.
Thank you so much. My comment is related to Yerno. I mean, he was speaking about two different development partners and also the humanitarian partners. Actually, we couldn't differentiate between them in Yemen. I'm sorry, I'm Fawzia Jafar from the Ministry of Public Health, Yemen. So I just feel like that we need to understand more about what's the difference between the development and humanitarian, because we are dealing with very supportive partners like WHO, World Bank, UNICEF, and we are getting support in humanitarian aspect as well as a development aspect. So do you please could you elaborate more on this so that we know really the difference between them? Thank you so much.
Thank you. And we can have a longer discussion as well, but I think very important is that we bring all of them together, and then also we have different funding streams, like we have USAID from one hand and PHA from another hand. We have European Union from one hand, we have ECHO from another hand. We have a number of these different funding tools as well, so it is not only to talk about those multilaterals like UN together, but then also looking how the funding flows, who are related, and then also how to bring them more together, because they have a different perspective. But I think, as the example is Yemen, the situations are also different. So we need to build on the country coordination structures which were there before as well in place. And very often, I think what Petra was mentioning about localization, very often we see the humanitarian coordination being more at the local level as well. So the key question is how to bring all these pieces well together, and it varies from country to country or even region to region.
Okay, so we have a lot of questions, sir. I can see you have questions. All of you can ask your questions after this session, but we will have to move out. Mila is pointing towards the door already because there's another session here. So please do ask your questions. Then we have two ministers of health here, and we wanted to learn from them tips and tricks to talk to Ministry of Finance. Don't forget to ask them about that. I want to learn about that too. So as we wrap up, each of you, tell us the one message, the one word you want to leave our audience with about building resilience and resilient health systems in fragile and conflict-affected countries. Starting with you, Jarno.
Very simple. Transitioning towards the UHC is also good when you get to the conflict situation.
Thank you, Dr. Khan.
Very simple also is anticipation. We have to anticipate more and more because we don't have enough resources.
Thank you, Dr. Corey.
We need to advocate for those who cannot advocate for themselves.
Thank you, Dr. Especially for Afghanistan, you're saying yes. Dr. Moreira da Silva.
Better align policy and finance with operations to rescue the SDGs.
Dr. Buhaib.
Peace, equity, and equality in the country level and at the regional level, it will be the key for this results in the health system.
Thank you very much. Thank you to our colleagues from UNOPS for organizing this session. Thank you to WHS and to Germany for being our partner in and being a champion for multilateralism. Thank you to you all.